Bismillah ar-Rahman ar-Rahim. Welcome again, my young dear colleagues. I'll talk to you today about an important topic in neurology practice. We will talk today about epilepsy. Epilepsy is a very interesting topic. So our presentation will be pretty long. I hope it will be interesting to you as to myself, and I'd like to use some Arabic explanations through my presentation just to ease the topic and clarify some points all through. First of all, we would like to refresh our memories on the concept of how does brain work. The cerebral cortex represents the highest center for sensory, motor, and higher functional processing, and in general, each lobe of the brain is responsible for processing a particular functions. We can say in general that frontal lobe processes motor, speech, and personality modalities. The parietal lobe processes sensory information. The temporal lobe processes the auditory and memory modalities, and the occipital lobe processes mainly vision. So, as you all know, neurons form the functional cellular unit that is responsible for communication throughout the nervous system. They have different sizes, different shapes, and in between these neurons there are some other neuroglial cells. These are the supporting main or back frame or main frame of the brain tissue, as astrocytes or oligodendrocytes, satellite cells, other cells that optimizes the neuronal functions and the conductivity that provide the maintenance of these networks of neurons and to protect the nervous system in general. This is a simple diagram that you can revise while you are studying. It includes most of the basic structure in our nervous system. Neurons communicate with each other and with other target cells through a specialized region called the synapse. And the synapse contains synaptic vesicles. These are like storage for the neurotransmitters on the presynaptic membrane that will release the neurotransmitter in the synaptic cleft or in the synaptic space on arrival of an neurological signal. This neurotransmitter is targeted to bind to the receptors situated on the postsynaptic membrane, and according to the type of the neurotransmitter, either it can be excitatory, inhibitory, or modulatory. The effect on the target cell is achieved. And as we can see in this diagram, we have the excitatory and inhibitory model of synaptic conduction. On the left side, we can see the excitatory neurotransmitters, and on the right side we can see the inhibitory neurotransmitters coming from the presynaptic vesicles and releasing the neurotransmitter into the synaptic lift, so as to bind to the postsynaptic receptors, achieving either an excitatory action potential or an inhibitory action potential. So in the beginning, we have to know some general definitions in the epilepsy field. In the beginning, the word epilepsy is a derivative of a Greek word meaning to be seized or to be overwhelmed by surprise. This is the root of the word. From the neurological or medical point of view, we have to differentiate between an epileptic seizure and epilepsy. Seizure, by definition, is a transient sign and symptoms due to abnormal or synchronous neuronal activity in the brain. Epilepsy, on the other hand, refers to a group of chronic neurological conditions characterized by recurrent epileptic seizures. بمعنى إن إحنا هنفرق دايما ما بين كلمة seizure وكلمة epilepsy. seizure هي النوبة اللي بتحصل للعيان. النوبة دي بتبقى نتيجة مشاكل ليها علاقة بالنيورونال اكتيفيتي. مجموعة من الساينز والسيمتومز بيجوا مع بعض يعملوا هذه النوبة. تمام؟ إنما epilepsy معناه recurrent seizures بقى. seizures بتيجي بشكل متكرر سواء بنفس الشكل أو بأشكال مختلفة. Okay, we have ictal terminology, and ictal event means any dysfunction occurring during an epileptic seizure. Post-ictal event, these are dysfunctions occurring after the seizure. Interictal period refers to the period between seizures when there is no ictal or post-ictal disturbances. Epileptic focus is defined electrophysiologically as the brain area that appears to generate the most prominent interictal epileptiform EEG discharge. آخر واحدة دي معناها إن الفوكس دي اللي هي معروفة بالعربي على إنها البؤرة. والبؤرة ما هياش إصابة، ما هياش ليجن، ما هياش حفرة. البؤرة عبارة عن مجموعة من الخلايا الوظيفة بتاعتهم الكهربائية فيها مشكلة. فهو الإلكتروفيسيولوجي بتاع الاريا دي، بتاع شوية الخلايا اللي في الاريا دي ما هماش مظبوطين، وفي الأغلب البؤرة بتبقى related إن هي دي أكتر حتة فيها interectal epileptiform activity موجودة في ال EEG. فده اللي مقصود ب epileptic focus، لأنها كلمة من الكلمات المشهورة ويمكن بتخوف كتير من العيانين وحتى الدكاترة، إن هو يعني عنده بؤرة أو ما عندوش بؤرة. هي كده كده البؤرة دي مش لازم تبقى إصابة أو مش لازم تبقى ليجن، هي ممكن تبقى عبارة عن مجموعة من الخلايا، وزي ما قلنا كده وظيفتهم الكهربائية فيها مشكلة. Epileptogenesis is the development of an epileptic disorder. سهلة، epileptogenesis. فمقصود بيها دايما انها ده initiation of the epileptic seizure، او يعني دي process of how the epilepsy is occurring to an epileptic patient. Epileptogenic zone, on the other side, is a theoretical concept, and it is its exact boundaries can only be implied from a variety of diagnostic information, including ictal events, interictal and ictal EEG, and neuroimaging, as we will present later on this presentation. فالإبيليبتوجينيك زون عبارة عن حاجة نظرية، ده كونسبت، مكان هو ده اللي بيبتدي فيه الإبيليبتوجينيسيس، شبه اللي احنا كنا لسه قايلينه دلوقتي بتاع الإبيليبتيك فوكس، ولكن هو مور ادفانسد، بياخد داتا مش بس من الاي اي جي زي بتاعت الفوكس، لا هو بياخد كمان داتا من الاكتال ايفنتس، من الهيستوري بتاع العيان، من النيورو ايمجنج اللي كمان اللي ممكن نعمله للعيان. Other definitions that are important in the epilepsy practice are those related to controlling the disease. So what we mean with control in epilepsy? Control actually is a term that is poorly defined with respect to epileptic seizures. The seizures can be considered well controlled when their frequency and or severity are reduced by treatment to some acceptable level for some period of time, but no specific criteria has been established. So it is not really defined in epilepsy field. The term control is a vague term that is rarely used nowadays. However, we can refer to a patient that he is seizure free when they no longer have disabling epileptic seizures. So if our patient is not experiencing seizures, so we can call them then they are seizure free for some period of time, let's say 1 year or so on. Epilepsy can be considered as resolved for individuals who had an age-dependent epilepsy syndrome and are now past the applicable age, or those who have remained seizure-free for at least 10 years with no seizure medicines for the last 5 years. So we have to discriminate or differentiate between this group of terms regarding the vague control concept of epilepsy. Epilepsy, on the other hand, we can consider this epilepsy as a refractory epilepsy, as a resistant epilepsy, when there is failure of 2 or more drugs and occurrence of 1 or more seizure per month over the last 18 months. يبقى احنا عشان نقول ان العيان seizure free خلاص لازم يبقى ما عندوش seizures بقاله فترة من الوقت، واحنا ساعتها بنقول ان هو بقاله seizure free لمدة هذه الفترة. لكن عشان نقول ان العيان resolved يعني خف بالبلدي كده، يبقى عندنا حاجة من حاجتين احنا محتاجينهم. يا اما العيان ده عنده age dependent epilepsy، يعني epilepsy من الانواع اللي بتيجي في عمر محدد وليكن في عمر الطفولة، وهو ما بقاش طفل فخلاص هو مش هيجيله النوبات دي تاني لان هو كبر. هو اتعالج في الاول وهو صغير وبعدين عدى المرحلة العمرية اللي مفروض بيجي فيها هذا النوع من النوبات، فالمتوقع كده ان هو ايه خف خلاص. يا اما لو القصة ملهاش علاقة بالايج ديبندنت epilepsy syndromes لعيانين الابيليبسي في العموم بقى، ان هو يفضل سيجر فري ما بيجيلوش نوبات لمدة لا تقل عن 10 سنوات. اخر 5 سنين فيهم يبقى لازم ما يكونش بياخد اي ادوية عشان توقف السيجرز. الناحية التانية قصة الريفراكتوري ابيليبسي او الريزيستنت ابيليبسي، الديفينيشن بتاعها هو كده اسطمبة عبارة عن ان انا فشلت ان انا اعالج العيان بدوايين او اكتر بجرعات مظبوطة ولفترات مظبوطة، ورغم هذا انا بديله الدوايين او اكتر ولسه بيجي نوبة او اكتر لمدة سنة ونص لمدة 18 شهر. طيب status epilepticus one of the neurological emergencies that we can face in our practice, and it is a condition in which epileptic seizures continue or they are repeated without recovery for a period of 30 minutes or more. فعشان اقول ان status epilepticus يبقى العيان يا بيجيله سيجر طويلة تقعد اكتر من نص ساعة، او ان يجي سيجرز في النص ورا بعض ورا بعض ورا بعض، بيفصل ما بيبطل يتشنج او بيبطل يحصل له الشكل المعتاد بتاع النوبات اللي بيشوفها، ولكن لا يستعيد درجة الوعي. فهو ما حصلش ان السيجر خلصت تماما وتروح ملاحقة سيجر جديدة جاية ويقعد ورا بعض لمدة تزيد عن 30 دقيقة. ده لازم يخش الطوارئ. ده واحد من النيورولوجيكال امرجنسيز المشهورة قوي في البراكتس بتاعنا. في كونسبت كمان definition اسمه epileptic encephalopathy، والepileptic encephalopathy is a term used to describe a clinical state in which there is changes in the cognition or other cerebral functions due to ongoing epileptic process. يعني العيان بيجيله نوبات بشكل متكرر، وهذه النوبات تسببت في مشكلة لها علاقة بالمعرفة بالكوجنيشن أو لها علاقة بالسيربرال فانكشنز أخرى whatever بقى كانت الكلام الحركة الإحساس أيا كان. وده غالبا بيحصل أكتر في الchildren في اليونجر ايج أثناء الديفلوبمنت، ويحصل uncontrolled epileptic attacks بتحصل ورا بعض، والعيان ما هواش بيتعالج بشكل كويس أو بشكل صح. ده بيأثر في الآخر على الوظائف العامة للدماغ، عشان كده بتسمى encephalopathy. فهي epileptic encephalopathy. It's a cerebral dysfunction, generalized or specific cerebral dysfunction due to occurrence of epileptic seizures. طيب عندنا كده تقسيمة قديمة برضو من خلال ال definitions. We can put some types for the epileptic attacks. Epilepsy can be considered primary or idiopathic, which are benign and age-related, mostly due to genetic disturbance. The other main type is the secondary epilepsies, or the symptomatic type, and the symptomatic type is due to lesions of the brain, either acquired or it can be something congenital or genetic in etiology. The third term here is the cryptogenic, and cryptogenic is probably symptomatic. It's not primary, okay? Yet the etiology is not known. يعني هنا في النقطة أنا مش عارف أحط إيدي على السبب، ولكن ده واحد ما هواش واحد من البرايمري ابيلابسيس. البرايمري ابيلابسيس ليهم تعريفات وليهم انواع محدده، ده مش واحد منهم. بس انا بالايمجز او بالانفستيجيشنز اللي معايا انا مش عارف اوصل بالظبط للسبب اللي عامل الابيلابسي، فساعتها بنحطه as a cryptogenic. لا هو يعني هو يعني سيمتوماتيك بس انا مش عارف اجيب ايه هو البرايمري بتاعه، هو فين اوله، لكن هو في الاخر شكله سكندري بس انا مانيش عارف احطه قوي. تمام. اخيرا عندنا التعريفين كده ريليتد للإبيلابسي. الإبيلابسي ممكن يبقى provoked، والprovoked seizures ده بيبقى acute symptomatic seizure that are defined as seizures that have an obvious and immediate preceding cause. Acute systemic or metabolic disturbance يعني exposure to toxins أو drugs، أو إن إحنا عندنا في direct insult حصل في السيربرال، فعندي acute cerebral damage زي stroke أو trauma أو infection. فده provoked seizure معناها إن في حاجة حصلت هي اللي أدت directly على طول بشكل مباشر إن العيان يجيله seizures. في برضو التعريف الأخير اللي هو febrile seizures. Febrile seizures are epileptic attacks occurring in children between the age of 6 months to 5 or 6 years, and they occur only with a rise in body temperature, and there is no evidence of intracranial infection or other defined intracranial cause that can precipitate the occurrence of epileptic seizure. فدي المعروفة على إنها تشنجات حرارية، ويمكن ده كونسبت شوية مغلوط ما بين الدكاترة النون نيورولوجيكال يعني physicians، إن استخدام أي عيان بيجيله حرارة أو بيجيله بعديها سيجر أو معاها سيجر فده فيبرايل سيجرز أو فيبرايل كونفولجنز. لا، فيبرايل كونفولجنز ليها شوية كرايتيريا كده، لأن هي واحدة من الحاجات اللي مفروض تروح مع الوقت، فعشان كده هي ليها وقت. هي دي age dependent، المفروض من 6 شهور ل5 6 سنين، وبعد كده ما بتحصلش، ولا قبل كده برضو بتحصل. يعني قبل 6 شهور ما ينفعش أقول على أي كونفولجنز إنها فيبرايل كونفولجنز، وبعد 6 سنين برضو ما ينفعش أقول على أي كونفولجنز إنها فيبرايل كونفولجنز حتى لو بتحصل مع الفيفر. فهو لازم يبقى مع حرارة، ولازم تبقى مع العمر من 6 شهور ل6 سنين، ويبقى ما عنديش كمان أي etiology أقدر أمسكه، مثلا يكون في انكفالايتس، يكون في مينينجايتس، يكون في حاجات زي كده، او عندي اي انتراكرينيال بقى بروبلم، هيموريدج، انفاركشن، واتس ايفر. وكمان العيانين دول موست بروبلي لما بيعملوا الاي اي جي ما بين الاتاكس ما بيطلعش فيه اي مشاكل. فعشان لا نخلط الامر، مش كل سيجر بتحصل مع الحرارة هي فيبرايل سيجر. لا، فيبرايل سيجرز ليها تعريف وليها شروط عشان نقول عليها انها فيبرايل سيجرز. طيب، الانسيدنس والبريفالنس اوف epilepsy. Why is it so important, this epilepsy thing? The incidence of epilepsy is about 50 per 100,000 of population في ال developed countries. So in the developing countries, as we all know, the incidence and the prevalence studies are not that strong and not that common. However, many of the limited studies that have measured the incidence and the prevalence of the epilepsy in developing countries have described that the rate can reach up to 190 patients per 100,000 of population. The prevalence of active epilepsy in many studies has been shown to be at 4 to 10 per 1,000 population, and this is a significant high prevalence rate between medical disorders. And definitely it has a socio-economic impact, limiting the productivity of the patient in a community, and may also cause many morbidities and mortalities between these epileptic patients. فده مهم لان ده بيعكس ليه احنا حاجه زي الابيلابسي بتبقى مهمه في البراكتس عندنا. ممكن تاثر على العيان بشكل سلبي، حمل يعني حمل فاينانشال طويل، علاج بياخد وقت، وكمان ممكن لو جات له نوبات وهو شغال وهو بيعدي الشارع وهو سايق، ده ممكن يسبب له اصابات او حتى يسبب وفيات، وكل دي تعتبر خسائر مجتمعيه ليها نيجاتيف سوشيو ايكونوميك امباكت بشكل عنيف. هنلاقي هنا الموست frequent reported etiologies للإبيليبسي في ال different income groups of countries. ففي الهاي income countries بيبقى most probably الحالات بتبقى traumatic in etiology، لكن كل ما بننزل هتلاقي التروما عمالة بتزيد. يعني احنا شايفين هنا ان التروما في الهاي income countries تقريبا واصلة ل 87.5%، ويجي وراها السيريبروفاسكولار ديزيز ب 75%، وبعدين بعديها تيومرز. لكن هتلاقي شوية فروقات بقى ما بين كل ليفل والآخر. لما نلاقي في اللو income countries هتلاقي أي نعم التروما هي ستيل أكتر واحدة، ولكن يجي وراها الانفكشنز، ويجي وراها مشاكل البيرينيتال اللي هي تقريبا أقل حاجة موجودة في الهاي income countries. بارازيتكس تبتدي تطلع يبقى 44%. فدي يمكن تقسيمة كده الاتيولوجيز بشكل عام ما بين ال different income group of countries. About 1/3 of people with epilepsy, no underlying cause can be identified. So epilepsy is more or less a multifactorial disease. Even in the cases with a major obvious etiological disorder, other factors like genetic or environmental factors can play a very significant part of the pathophysiology of epilepsy. We have a wide range of etiology that varies in different age groups. And in general, we can expect that congenital and perinatal conditions may be common etiologies for childhood onset epilepsies, whereas other non-genetic causes can be expected to be the etiology of epilepsy in the adult life. And we can see over here a small table that can summarize different age groups with the most common etiology of epilepsy for each group. And if we have some few examples in the first few months of age, neonatal asphyxia or hypoxia, infections, inborn error of metabolism can be the common causes. In the first 2 years, a sequelae of the previous ones, of course, together with inborn errors or vascular causes or infections. On the other side, in the adulthood, we can notice that from 20 to 40 years, trauma, brain tumors, alcohol consumption, vascular diseases, there can be causes of epilepsy occurrence. Later on, tumors will be more apparent to be an etiology, and over 60, vascular and tumors are the main causes, together with neurodegenerative disorders. So, what factors that can influence seizures? Seizures are usually influenced by some daily activities that can be able to precipitate seizures in an epileptic patient. These factors includes late sleep or sleep deprivation, photic stimulation, and photic stimulation is like in front of tube screens or tube lighting, and here we have to differentiate also between the tube screens. Tube screens اللي هي كانت التلفزيونات القديمة، السي ار تي بتاعت زمان اللي كانت ليها تيوب من ورا، مش ال LCD، مش الحاجات الفلات سكرين. الفلات سكرين أقل شوية، ولكن برضو هي ليها photic stimulation effect عشان الريفريش ريت بتاع الصورة اللي بيطلع قدامنا على الشاشة ده ممكن يبقى بيعمل influence for seizure occurrence. برضو على الناحية التانية التيوب لايتنج ده اللي هو كل الإضاءات الأنبوبية اللي هي شبه النيون كده، أو شبه اللمبات الموفرة اللي هي بتبقى ملولوة، بتبقى أنبوبية الشكل. فده المقصود بكلمة photic stimulation. sympathomimetics، وأشهر حاجة في السيمباثوميماتكس هي أدوية الرشح، أدوية تركيبات اللي بيبقى فيها حاجات توقف الرشح أو decongestants، تقلل الاحتقان. فالتركيبات دي لازم تستخدم بحذر شديد مع عيانين الإبيلابسي. fever as we said, fever can influence seizures. toxins أو drugs زي معظم المخدرات معظمها بتعمل نوبات، حتى لو كانت المخدرات دي حاجة inhibitory. يعني الترامادول مثلا واحد من الحاجات المخدرات المشهور قوي ان هي اخدانه يعمل سيجرز وتبطيله يعمل سيجرز الاثنين، يعني الوذرول بتاعه يجيب سيجرز، واخدانه اساسا في العادي كده برضه يجيب سيجرز. الالكول والالكول وذرول كان انفلونس سيجرز. هايبوجلايسيميا طبعا ممكن، وفي عيانين الابيلابسي او عيانات بقى الابيلابسي المينسترال سايكل كمان ليها ايفكت قوي جدا مع الهرمونال تشينجز اللي بتحصل فيها، ان ده ممكن ينفلونس الابيلابتيك سيجر. Knowing that epilepsy is a very variable condition, it has very variable presentations, it was very needed that we have a system for classification of this disorder. In neurology and in epileptology in specific, we have an international league against epilepsy, a very strong organization of physicians from all around the world, engaged to this task for over now, we can say 40 or even 50 years, proposing different classifications that have been revised periodically. The commonly used classification back in the years was the first International League classification in 1981, and this uses only two criteria: the clinical form of the epilepsy and the EEG abnormality, and this was considered a big limitation for many neurologists. The classification was, as we can see in this slide, in three different parts. The first is known as partial epilepsy, and the second is known as generalized epilepsy, and the third is unclassified epilepsy seizures. Now, at the meantime, we no longer use this classification. In 1989, the International League presented a very sophisticated and very busy classification, including all the epilepsy syndromes with many names and many complicated terminologies that are here and there, and this classification was very difficult to be used in the daily neurology practice. Later on, in 2017, after so many revisions and so many versions of epilepsy classifications, International League Against Epilepsy introduced a modified 1981 classification, replacing some old terms with some new ones to be more easily used and more easily comprehended by any neurologist all around the world dealing or talking about epilepsy disorders. This classification will be our core in the next few slides to explore some of the different presentations of epilepsy. First of all, we will start by focal aware seizures. So, focal aware seizures are seizures in which consciousness is not impaired, and they are due to focal cerebral disease. There are some subtypes of the focal aware seizures. It can be a motor focal aware seizure, a sensory, an autonomic, or a psychic focal aware seizure. The motor focal aware seizure is, for example, like jerking or a spasm or posturing of one limb, and it can be it can spread from one part to another part of the body with what's known as Jacksonian march. We describe this spread by the term Jacksonian march. المقصود هنا ان الموتور سيجر بتبقى واخده مكان معين، جزء معين من الجسم. ممكن يبقى upper limb، ممكن مثلا يبقى one lower limb، ممكن يبقى الفيس، وممكن ان القصه تبتدي في جزء، مثلا ان يبتدي مثلا في الثumb، وبعدين ياخد الهاند، وبعدين ياخد الفور ارم، وبعدين ياخد الارم، فليه مارش بيسبريد فيه كده، واحنا المارش ده بنسميه جاكسونيان مارش or Jacksonian motor focal aware seizure. The other type is known as sensory focal aware seizures with tingling or numbness symptoms. ده less common as كمان an electric shock like feeling، ممكن تبقى burning، حاجات زي كده. الاوتونوميك focal aware seizures بتبقى كلها حاجات autonomic، changes في ال skin color، changes in the blood pressure or the heart rate، pupil size، piloerection. بيحصل changes دي في attacks، في نوبات، ويطلع في الآخر إن القصة دي epileptic لما ناخد الهيستوري بشكل مظبوط ونعمل investigations بشكل مظبوط، يطلع في الآخر إن هي epileptic. It can be also psychic focal aware seizures presenting with cognition problem or affective symptoms، hallucinations، حاجات ليها علاقة بالمود، حاجات ليها علاقة بالperception، حاجات من هذا القبيل، وتبقى البرزنتيشنز كلها عبارة عن psychiatric symptoms. برضو بتيجي في attacks، في نوبات، وتروح تيجي فجأة وتظهر وبعدين تروح، والعيان بيرجع طبيعي، وكل دول بيبقى معهمش أي اضطراب في درجة الوعي. We have to remember that the focal aware seizures بيبقى the consciousness is not impaired. On the other hand, we have the focal impaired awareness seizures that is accompanied by altered consciousness. About 60% of the temporal of the focal impaired seizures arises from the temporal lobe, 30% arises from the frontal lobe, and 10% arises from other cortical areas, including the parietal and the occipital lobes. This type of seizures have three components that are usually characteristic for them. We have an aura, and the aura is equivalent to more or less a focal aware seizure, followed by the stage of altered consciousness, which is the second characteristic of this type of seizures. The next type is the generalized seizures, and generalized seizures consciousness is almost invariably impaired from the onset of the attack. احنا عندنا هنا extensive cortical و subcortical involvement، فالكورتكس كلها فيها لخبطة، او السب كورتكس كله فيه لخبطة، فالكونشس ليفل بتاع العيان لازم بيبقى متداول. Motor changes are usually bilateral و more or less symmetrical، وال EEG patterns بتبقى برضو bilateral و synchronous و symmetrical over both hemispheres، ودول we will see some examples later on this presentation. The main or the common types of generalized seizures, we have at first the typical absence seizures. Typical absence seizures, these are seizures that compromises an abrupt short loss of consciousness, hence we call them absence. Cessation of all motor activity. During these attacks, the tone is not affected, and there's no falling down on the ground even if the patient is standing up. The patient is not in contact with the surrounding, and he is also inaccessible. The attacks, as they abruptly started, also they abruptly end, and the previous activity is usually resumed. There's no post-ictal confusion, yet the patient usually is unaware that the attack has occurred to him. And these attacks can be repeated during the day, reaching to up to hundreds of times per day. فالtypical absence المهم قوي فيه ان احنا نعرف ان هو بيبتدي بسرعة قوي فجأة، وبيروح برضه فجأة، والتون ما بيحصلش فيه حاجة، فالعيان ممكن قوي يبقى قاعد و يفصل، اكننا شدنا الفيشة، يفصل كل الاكتيفيتي بتاعته، ومتعرفش انت تكومينيكيت معاه، ولا هو طبعا بيكومينيكيت مع اي حاجة حواليه. وبعدين لما بيخلص اكنك رجعت الفيشة تاني، بيكمل من حيث انتهى، هو كان فين وهيكمل من النقطة دي. والمشكلة ان هي لما بتحصل كتير قوي، بالذات لما تحصل في الأطفال، هما ما بيبقوش واخدين بالهم أصلا إن في نوبة حصلت، فبيفوتهم حاجات كتير قوي، سواء كان مثلا في الدراسة أو في تمرين أو حاجات زي كده. بيفوتهم الحتت اللي هو حصل فيها الأتاك، بتبقى بالنسبة له ما حصلتش، فهي في جزء أو أجزاء من الأحداث اليومية بتقع منه، هو بالنسبة له ما عاشهاش.
The absence seizure, which used to be known as a petit mal seizure. This type occurs almost exclusively in children and will usually disappear by the time the child reaches adolescence. An absence seizure is characterized by 5 to 15-second lapses in consciousness, during which the child may blink rapidly, roll the eyes, or smack the lips. This can sometimes be misinterpreted as daydreaming, as the child will be unaware of what is happening. Some children can experience hundreds of these small seizures in a single day, which can interfere with learning. After a seizure, the child may be anxious because of a missed period of time, and therefore some of what he or she was involved in. Reassurance is important. Calmly explain that the child has had a small seizure and is all right. There's no need for any type of active first aid. The child's parents should be made aware of the timing and the number of seizures so that they can report this to the child's physician.
فزي ما شفنا كده في الفيديو ده، ان البنت حصل لها الابسنس اتاك وهي بتلعب كوتشينه، والورق ما وقعش من ايديها، وهي نفسها تنتها قاعده، ولا هي وقعت ولا الورق وقع ولا اي حاجه. وموست بروبلي اللي بيحصل ان لما السيجر بتخلص، زي ما قلنا كده العيان بيواصل الحاجه او الاكتيفيتي اللي هو كان بيعملها من حيث انتهى قبل ما النوبه تحصل. ده شكل تاني، برضو العيانه بتعد فهي العينة بتعد، وبعدين حصل السبيتش ارست اللي هو دي النوبة، الكلام وقف عند رقم، وبعدين هم حتى قالوا لها كملي عد، هي كانت ساعتها inaccessible، وبعدين فكت النوبة وهي كملت من الرقم اللي كانت وقفت عنده، كملت بعد كده 59 60 and whatever. طيب another type of generalized seizures is known as atypical absence seizures. Atypical absence seizures are like the absence seizures but with some differences, so it is called an atypical seizures. Atypical seizures differ from typical absences in some clinical and EEG points. Usually the atypical seizures are longer in duration, associated with tone changes, and the onset and the cessation of the attack is not so abrupt as in the case of typical absence. Patients appear relatively inaccessible or even maybe ambulant with support during the attack. فدي الفروقات اللي ممكن تحصل او ان احنا ممكن نلاقيها ما بين التيبيكال والاتيبيكال seizures. Atonic seizures one of the most severe form of the classic trope attacks. Atonic means we have lost the tone of the muscles, and so all postural tone is suddenly lost, causing a sudden collapse to the ground. The tone changes can be restricted to one region. مش لازم تاخد الجسم كله، لكن بتاخد region على بعضه، ساعتها resulting in for instance in nodding of the head or bowing moving or sagging at the knees، حاجات زي كده. فالاتونيك seizures mainly بيحصل فيها sudden loss of tone of muscle tone. Myoclonic seizures. These seizures are characterized by having a very brief and rapid contraction of a muscle or a muscle group or several muscle groups. Definitely in this situation due to cortical discharge. It can be single or repetitive, varying in severity. ممكن تبقى حاجات بسيطة جدا عبارة عن تويتشز زي هزة أو فزة بسيطة قوي، أو ممكن توصل إن هي من كتر ما الفزة دي سريعة وشديدة إن هي تسبب إن العيان يقع، أو إن الحاجة اللي هو ماسكها في إيده تطير من إيده وتقع برضه. Myoclonus is usually influenced by noise, by photic stimulation, by percussion. العين لما يتخض من صوت جامد، من خبطة جنبه، من القصة بتاعت الفوتيك ستيميليشن اللي احنا كنا قلناه في الأول. معظم العيانين بتوع المايوكلونيك سيجرز بيبقوا very sensitive للأنواع دي من الستيميليشن. The classic and the most famous generalized seizure or even epileptic seizure to the public is the generalized tonic-clonic seizures. Generalized tonic-clonic seizures are characterized by an initial loss of consciousness, and usually, or in many cases, we can see an epileptic cry at the first, and the patient falls down. Even if he was standing or sitting down, he usually falls, and there is a very brief period of a tonic flexion, followed by a longer tonic phase of axial extension, with the eyes rolling up, jaws are clenched, limbs are stiff, adducted and extended. During this tonic phase, the respiration ceases, and cyanosis can be noticed easily on the patient. The tonic phase lasts about 10 to 30 seconds, and it is followed by the clonic phase. And the clonic phase, we have the famous convulsive movements. Usually all of the body is involved, including all the limbs, the forelimbs, the jaw, the facial muscles, and saliva may froth out of the mouth. Tongue biting can also occur, making this froth some sort of bloody stained one. The clonic phase lasts about 30 to 120 seconds, so it can reach to about 2 minutes, over the half a minute in the previous tonic phase. And this is finally followed by a brief tonic contraction of all muscles, and may incontinence, urinary incontinence may occur at this time. The final phase lasts about 2 to 30 minutes with post-ictal flaccidity. Then the conscious level is slowly regained.
This is a generalized seizure, or one in which the whole brain is involved. It is also convulsive in nature. The seizure starts with a person crying out, losing consciousness, and falling to the ground, and then developing a generalized stiffening of the body. Respiration may briefly cease, which will cause the person to turn dusky blue color. Following this, there are alternate periods of spasm and relaxation of the muscles, so that jerking movements of the face, arms, legs, and trunk occur. The person may bite the tongue and bleed from the mouth, making grunting sounds, salivate heavily and become incontinent. After 1 to 3 minutes, the seizure will subside and consciousness will be regained. Afterwards, the person may be confused, have difficulty speaking, complain of a headache, and wish to sleep.
فزي ما لاحظنا هنا في الفيديو معظم المواصفات اللي احنا كنا قايلينها جت وحصلت في الأحداث يعني بتاعت الإكتال إيفنت. مهم بس إن احنا ناخد بالنا إن الأكامبانينج بيرسون مع البيشنت في حد كان عايز يديله معلقة أو كده عشان يحطها في بق العيان في بق العيانة عشان ما تعضش على لسانها أو عشان ما تبلعش لسانها أو whatever. وهو كان واضح إن هو عنده معلومة إنه ما ينفعش إن احنا نعمل كده، وده واحد من الحاجات الصحيحة جدا إن احنا ما ينفعش نحط أي حاجة ناشفة ما بين سنان العيان جوه السيجر، لأن ده ممكن يكسر السنان يعور الحاجة اللي داخلة. يعني الحاجة اللي داخلة لو صباع مثلا بني آدم أو إيد بني آدم ممكن أوي إن هو يعضه وتبقى عضة الحقيقة مؤذية يعني. فبناخد بالنا إن احنا نجيب العيان على جنبه، ويمكن ده الدروباك الوحيد اللي موجود في الفيديو، إن هو مفروض العيان يتجاب على الجنب سواء يمينه أو شماله، عشان بس لو حصل vomiting أو حصل أي مشكلة في البلع ما يحصلش aspiration، ما يخشش الكلام ده جوه الرئة. The last type that we will explain as an examples of generalized seizures are known as epileptic spasms. And epileptic spasms are characterized by sudden, bilateral, symmetrical contractions of the muscles of the neck or trunk and or limbs. The spasm grow in frequency with time to occur hundreds of times per day, and they can show also a strong tendency to cluster. Cluster معناه انهم بيحصلوا في مجاميع ورا بعض clusters. In the most common type هو الflexor muscles are predominantly affected, and the attacks takes the form of a sudden flexion of the arm, maybe also the legs, وبتبقى عاملة زي اللي هم كانوا زمان بيبقوا عند السلطان كده ويروحوا عاملين سلام كده، بيبقوا نازلين كده عاملين التحية كده للسلطان، وعشان كده حتى هم سموها سلام اتاكس في كثير من الكلاسيفيكيشنز الموجودة والقديمة يعني. في برضه اكستنسور كمان سبازم بس دول less common، فهو المور common هو الفلكسور سبازم، فلكسور epileptic spasms. So after we knew the different types and the main pathophysiologies behind the epilepsy, here we come to the stage of investigating an epileptic patient. And when we say epilepsy, we have to mention the electroencephalography. Digital electroencephalography, or digital EEG, is an electrophysiological monitoring tool to record electrical activity of the brain. Usually it is non-invasive. However, there is another invasive type of EEG recording. It's known as intracranial EEG, where the invasive electrodes are positioned on the cortex itself. Major types of EEG nowadays are the routine EEG, that is done for about 20 minutes. It's like 15 or 20 minutes in duration. There's long-term EEG, and the long-term EEG can be extended from 2 or 3 hours up to 8 or 12 hours. In some specialized units, the long-term EEG can reach up to a few days, like 48 or 72 hours of continuous recording all around the clock. We have also the long-term EEG with video recording, just to record the seizure occurrence by video and synchronized EEG recording at the same time to see the picture of or the description and all the details about the event in the video recording with the EEG recording hand in hand. EEG provides a very supportive tool in the diagnosis of epilepsy. However, it's not a sure diagnostic one, and we have to always remember this point. History and the seizure description are usually the starting key points for a diagnosis of epilepsy. Longer EEGs and more advanced techniques are usually needed in the query, non-straight or non-prototype cases. And we have to remember, as we said, EEG is not a sure diagnostic tool. Not every abnormal EEG is an epileptic one. So as we can see here, EEG can be abnormal in non-epileptic individuals. It can be abnormal in migraine patients, in autistic children, in children with ADHD, or even adults with ADHD, and surprisingly, it is abnormal also in about 3% of normal population not complaining from anything, and they do not have any medical issues. I'll show you some examples of EEG recordings. Here we can see generalized polyspike waves at this interval of time, and these are another synchronous polyspikes coming from all over the cerebral hemispheres. In this one, we will notice that we have a very, very, very abrupt and sudden beginning of the abnormal discharge, with also a very abrupt end of this abnormal discharge. And this is very, very diagnostic for typical absence. As you can remember, we have just said that typical absence has a very abrupt start and a very abrupt end, and this EEG is going very much with these characteristics. On this one, we have some left temporal starting epilepsy or starting focal seizure with an obvious bilateral propagation. So it started from the left temporal lesion and then it propagated all over the cerebral hemisphere. The second important investigation in an epileptic case is the neuroimaging, and in particular the magnetic resonance imaging, or the MRI, that can identify secondary epilepsy and identify its etiology. As we can notice here, we have here a lesion in the medial temporal region of this patient that is not present on the other side, and there are further investigations that can use data from EEG and the data from the MRI to be combined together and give me what's known as the epileptogenic zone, the area where the neurons are disrupted or abnormal, causing the epilepsy to occur in the first place. And as we can see here, this is like the first, the previous MRI image with the lesion on the medial temporal region, and the EEG data is pointing to the same area from the EEG on is congruent with the area of MRI. So finally, we have reached the last sector of our long presentation: how to treat epilepsy in your practice. In general, we have to start treatment with a single anti-seizure drug with a proven efficacy for the seizure type or the seizure or the epilepsy syndrome in question, and or the patient is presenting with. Do not forget the adverse effect profile of all anti-seizure drugs and the medical history of the patient during this drug selection to avoid any contraindications of this drug or that one. Failure of seizure control after proper drug choice for an adequate duration mandates you to try to shift to another anti-seizure drug with a different mode of action. Combination of two drugs or more is usually needed in severe cases or in also in resistant ones known as refractory epilepsy. So the masters of anti-seizure drugs that we will have to know some important points regarding them. We will start by one of the oldest drugs known as phenytoin. Phenytoin is still used nowadays as it is available in an IV form, intravenous form. It is used for all seizures types except absence and myoclonic seizures, and it is a very effective anti-seizure drug for all ages. It exerts its anti-epileptic effect by binding to and prolonging the inactivation of the voltage-gated sodium channels on the neuronal cell membranes. At high concentrations, it can also inhibit axonal calcium ion channels, and there is a query mode of action that it can bind to the peripheral type of the benzodiazepine receptors in the brain membrane, causing also an inhibitory effect. This strong old drug was usually one of the best drugs to be used. However, this was applicable like now around 40 years ago. And nowadays it is not one of the ever advised medications in epilepsy patients. This is due to its very bad profile of harmful adverse effects. As you can see, it has many adverse effects can happen to the patient on phenytoin. However, the ones with the red are the most serious ones. It can cause hypersensitivity, severe hypersensitivity, and rash, gingival hyperplasia, hirsutism, hepatitis, and bone marrow hypoplasia. The next drug in our list is the carbamazepine, and carbamazepine is widely used in generalized tonic-clonic seizures and much widely used in treatment of focal seizures. However, we have to remember that it can worsen the absence and the myoclonic seizures. Carbamazepine binds to the neuronal sodium channels in the pre and post-synaptically, and this binding results in the blockage of these channels. It also blocks the NAMDA receptors, activated sodium and calcium flux, may also be contributory as an anti-seizure effect. Regarding side effects of carbamazepine, it has a way much less side effects compared to phenytoin. The ones that are important for us to notice or to investigate and follow up is the occurrence of leukopenia and hyponatremia. Leukopenia is the decrease in the total leukocytic count or the total white blood cell count, and hyponatremia means the decrease of sodium levels in the blood. The third one is sodium valproate, and the sodium valproate or valproic acid is one of the most ever used anti-seizure medication, and it is used for all seizure types, and it can be considered a broad-spectrum anti-seizure drug. The mechanism of action is not entirely clear. However, it is supposed to be anti-seizure effect through increasing the synaptic GABA concentration and activation of the GABA sensitizing enzymes, and also inhibiting the GABA catabolism through inhibiting the GABA transaminase. So, as we know, GABA is an inhibitory neurotransmitter, and its increase will induce inhibition, and decreasing its catabolism also induces inhibition. Valproate also inhibits excitatory neurotransmitter induced by the aspartate and glutamate. To some extent, it has a modulatory effect on the voltage-gated sodium currents, inducing also a blockage over the sodium channels, inhibiting the excitatory neurotransmitter impulses. Sodium valproate has some adverse effects as any other drug. The most serious one is the occurrence of pancreatitis. However, it's very rare to occur. However, the common side effects that can occur with the usage of valproate is hair thinning and hair loss, weight gain, polycystic ovarian syndrome, and teratogenicity, and therefore this drug is considered contraindicated in any female during the childbearing period or childbearing age. Later on, we had a relatively newer drug called lamotrigine, and lamotrigine is like the upgraded carbamazepine. It is used in adults and in children for focal and focal to bilateral seizures. It is also effective in generalized seizures. And this drug acts through blocking the voltage-gated sodium channels. As I just told you, it's very similar to carbamazepine. It has an anti-glutamate and anti-aspartate actions. Also, it can modulate voltage-gated calcium channels at the N-type calcium channel, which is very excitatory channel. So the modulation of this channel conductions can modulate an epileptic seizure. Lamotrigine is one of the safe drugs nowadays. However, it can induce rash if the patient is allergic to the lamotrigine. Sometimes this rash is severe and serious, can be life-threatening if it was neglected. However, also this rash is not that common, and usually we titrate the drug to the dose or the target dose we are needing gradually and step by step. We just start low dose and go up slowly every 2 weeks, about 2 weeks, to avoid such a serious and severe side effect. Topiramate is another anti-seizure drug in our master's list. It can be used in focal and in generalized tonic-clonic seizures. Topiramate acts through the inhibition of the voltage-gated sodium channels, inhibition of high-voltage calcium channels, potentiation of the GABA-mediated inhibition, and introduction of the AMPA receptor activity. However, topiramate can induce two common side effects, depression and anorexia, causing significant weight loss, and these two adverse effects can be not tolerated by the patient receiving topiramate. The last one in our master's list is the levetiracetam, and levetiracetam is a very new drug, and by new I mean it's like now around 15 years or maybe 20 years in the market. It has a very unique mode of action among even the newer anti-seizure drugs. It is very effective from the initial dose. It has a very fast onset of action, and the mechanism is very different from any other anti-seizure drug. It's very tolerable with minimal pharmacokinetics and minimum drug-drug interactions. This molecule is used in all seizure types, almost all seizure types, and it is considered the newer broad-spectrum anti-seizure drug after the valproate we just talked about. Levetiracetam acts as an anti-seizure drug by selectively binding to a synaptic vesicle protein known as SV2A, and this this vesicle is involved in the synaptic vesicle exocytosis and the presynaptic neurotransmitter release. So this novel binding is not shared by any other anti-seizure drug. That's why it is considered an anti-seizure drug with a unique and novel mode of action. It has also a neuroprotective effect and very few side effects, as I just said. However, it can, in some patients, induce some behavioral or mood changes. So our final slide, this is other names and other anti-seizure drugs in a table presenting the oral bioavailability, the time to peak levels, the metabolism, the main metabolism targets, and the half-life of these different names of molecules, old ones and new ones. It's not mandatory for you to know this table. Just I needed to tell you that we have nowadays a variable and a long list of anti-seizure drugs. These are not all of them, by the way, that can be used in the treatment of epilepsy patients. So again, I'd like to welcome you once more to our module, and I hope this was not a very hard topic for you. Anyone with any question, please feel free to communicate with us through the LMS or through our sessions, either in the clinical-based learning sessions at Badr Hospital or the seminars at the college building. I hope to see you soon, and good luck for you all.